Again, welcome. My name is Lauren Becker, and on behalf of the National Association of Community Health Centers, I'm really excited to welcome you to today's Million Hearts Learning Lab, Sprinting to Hypertension Control and Cholesterol Management. I have a few quick reminders before we get into our speakers. Today's Learning Lab is being recorded, and we will send the recording as well as the slides out to all attendees after the call. All attendee lines have been muted and the chat has been disabled for this webinar. Instead, we invite you to submit your questions for our speakers through the Q&A function at the bottom of your screen. You can also upvote or comment on questions submitted by other attendees if you would like to participate in the conversation. The Million Hearts Learning Lab is a joint effort between the Million Hearts Initiative at the Centers for Disease Control and Prevention and the National Association of Community Health Centers. The Learning Lab always consists of 3 parts: a brief pre-work video and a quick survey to collect questions for our speakers, and this live 45-minute webinar that you are attending today. If you didn't get a chance to watch the pre-work video, I believe we just dropped that link in the chat, and we will also send it out with the recording of this session. Our learning objectives for today are to identify short, impactful, one-time strategies that can move the needle towards hypertension control and cholesterol management, discuss successes and challenges from both the health center and the network perspectives to implementing these strategies, and offer examples of impactful actions other healthcare organizations can take to move the needle on hypertension control and cholesterol management. Lastly, I have a quick disclaimer before I introduce our moderator. The opinions expressed by the speakers in today's Learning Lab do not necessarily reflect the opinions of HHS, CDC, or the Public Health Service. And now I have the pleasure of introducing our moderator, Chris Asperson. Chris is the lead quality improvement consultant on our NAC's Million Hearts projects. She is also a talented writer and the commissioner of the City of Des Moines Civil and Human Rights Commission. Welcome, Chris.
Thanks so much, Lauren. Appreciate being here. Very excited about today's session. We will go ahead and go on to the next slide and talk a little bit about our work. So NAC has been supported by the CDC since 2014 to focus on improving blood pressure control under the Million Hearts Initiative. In 2018, CDC expanded our work to include cholesterol management and really focused our blood pressure control efforts on people from racial and ethnic groups with disparate outcomes, specifically African Americans with hypertension. NAC works with community health centers, which primarily serve people with lower incomes and also serve other underserved populations. So given this focus, you can see how the newest NAC Million Hearts Improvement Project, which we call Preventing Heart Attacks and Strokes in Primary Care, really supports several of the Million Hearts 2027 priorities. On the next slide, you can see NAC's interactive roadmap tools, which is a really great place to start for those of you interested in focusing on either blood pressure control or optimal statin use. For both projects, these were a way to guide teams very clearly in choosing the most impactful intervention strategies with really the ultimate goal of improving outcomes. So we worked with our colleagues at the AMA to develop these tools, and they've really served as guideposts for both of our projects. They were informed by studies and guidelines, and they're also available on the NAC website along with many other resources. So it's hard to see on this slide, but it starts with our teams really looking at their performance in blood pressure control or optimal statin use, then doing an assessment of what intervention strategies are currently in place at their organization. This really helps guide the team to the strategies they need to put in place or enhance. And really the goal is to begin with core strategies. There are 2 more pages to each resource that include elective and capstone strategies. And what we found is a lot of organizations that are underperforming, not quite meeting the benchmark or their goals, are really focusing on elective strategies, but they are missing the core processes that they really should start with. So the next slide is the visualization of our project outcomes. So we started with the roadmaps that you just saw, and we had our teams pair their chosen interventions with metrics. And some of those metrics you're going to be seeing from our speakers in a little bit. But this slide shows that for our blood pressure control in African Americans project, we improved blood pressure control and average systolic blood pressure, but we really still need to work on medication intensification. And for cholesterol, our teams achieve results in cholesterol screening and optimizing statin therapy, but really need to improve prescriptions that occur during encounters with the patients. So on the next slide, we talk about the breakthrough activity. So to improve these areas that you saw are a little bit out of balance on the previous slide, we gave our teams a breakthrough activity challenge, or a short sprint challenge, if you will. So they came up with activities to target clinical care teams, the leadership, or the patients, or all three if they chose. But they really needed to form an implementation plan, and then they would present the results 90 days later at our next year project's kickoff call. On the next slide, you can see some examples of the activities that really made medication initiation and intensification, which are the right things to do, the easy things to do. And you're going to hear about a couple of these activities now. So on the next slide, you can see our speakers. We talked about community health centers when we started, and these two leaders that you see here are part of what we call an HCCN, or Health Center Controlled Network. HCCNs help health centers improve quality of care and patient safety by using health and information technology to really reduce cost and improve care coordination. And both of these women do an excellent job of just that. So please help me welcome Dr. Stephanie Courtney, who is supervising epidemiologist at Cincinnati Health Department, and Stephanie Smith, who is manager of clinical quality at Health Choice Network. Thank you both so much for being here. All right, so I'm actually going to start with Stephanie Courtney, and want to hear a little bit about how your health center and network how did you identify your sprint activity and what factors were considered in this?
Good afternoon. Thank you for having me. So the way that we identified this sprint activity, so the activity that we performed was we used a campaign style text message that we sent out via our bidirectional text software that's integrated with our EMR. And we targeted patients that were uncontrolled hypertensive and that were either on monotherapy or on no therapy. And so we identified this just because it was a minimal lift in terms of inputs. We already had the text message software in place, and we already had the report that was being generated that we could use to kind of filter to the patients that we wanted to target via the text message.
Wonderful. And Stephanie Smith, can you tell us a little bit about your activity, how it was identified, and what factors were considered?
Sure thing. So, thinking about the activity that we decided to work on as a health center controlled network, we really wanted to find a way to help our health centers understand the perspective of their clinicians and care teams in terms of statin therapy. And so, thoughts around education relating to the guidelines for statin therapy, even clinical content needs that might be arising within those different groups of our participating health centers. And we, on this graphic that you're looking at here, you could see some of the ways that we engaged our health centers in that continuum from the patient being able to engage with the provider. We developed a lot of the statin tools that have been performed through this initiative for Million Hearts into the electronic medical record system and Epic as a communication tool so that health centers and care teams can provide that education to patients either in advance of the visit to help engage them in the conversation during that encounter. Once they leave that health center, then there's an opportunity to assess their medication adherence, and there are some tools built within the system to help them do that. But provider engagement and development in that process from the care teams was critical for us to understand how we can make the biggest impact. So on the next slide, we actually have a form of the survey that we conducted. So it was anonymous. The only thing that we knew was if they were part of the participating health center within our network for Million Hearts. And we asked some key questions around their understanding of the statin therapy guidelines, also how to utilize the risk calculator for ASCVD. And as I had mentioned, that call out for clinical decision support within our electronic medical record. So understanding if they had exposure to that, was there some opportunity for us to provide some additional engagement around the tools available to them for that? And then also getting to some of the examples where there were some barriers in that process for that discussion with patients around statin therapy and where the recommendations may not have been clear. And so we were very happy to take this on as a health center controlled network so that that burden was lifted off the shoulders of health centers. And then we could provide them also with this data so that they had an understanding of what are some of the additional breakout activities or roadmap strategies that they could look at from a QI perspective. And so if we go to the next slide, here we're taking a look at just some context here. We think about our health center control network providing a house to health centers and health centers really making that house a home. And so when we look at the slide here on the screen, we think about the way we enable that through providing different accurate reporting tools for the cohorts for Million Hearts, training on the use of reporting and documentation tools. With that, we do have Epic clinician champion teams. So we have clinicians that actually help to lead trainings to help educate on those statin therapy guidelines, as well as promote the tools that are built within the system for that. And then the level up part is thinking about the clinical decision support tools and how we can make some improvements on those so that it shows up exactly at the right point of the process. Exciting things for the way our health centers execute some of the strategies is, of course, running those reports, setting aside time to help review that with their clinicians and their care team members so that they understand where they stand in the process. Our health centers have also done a lot of amazing things around the way of establishing incentive programs, such as recognitions or bonuses. And so here we have on the screen is a shout out for Portia at Ecom. So they actually decided to do a friendly competition within their clinicians and care teams about being a heart saver. So thinking about those checker badge goals from HRSA for the Million Hearts items, being at 80% or higher, looking at sites that are performing in that avenue and giving them recognition in the form of the trophy that you see here on the screen.
This
So if we
is
go to the next
wonderful.
slide, I'm going to pass it back to Chris.
Okay, thank you so much, Stephanie. So really a couple of themes, a lot of great work in both your community health center in Cincinnati and the HCN Health Choice Network. A couple of themes of really reducing the burden and finding ways to make things easy, especially since this was a 90-day activity, and really starting where people were at. Stephanie Smith, you talked a lot about making sure to understand what the barriers were and some of the other things by doing that survey, which was fabulous. And then Stephanie Courtney, thinking about things that were already in place and would be a easy lift to lift up. So want to go to the next question. And again, I'll start with you, Dr. Courtney. What did it take for leadership buy-in to complete this 90-day activity? Anything in addition to, making sure to leverage resources that you already had, and then anything about clinician buy-in as well?
Thank you. In terms of this 90-day sprint activity and leadership buy-in, because it was such a minimal lift in terms of resources needed, the actual buy-in itself was happened fairly quickly. Our COO and our medical director approved the text messages that we had put together. And then the added benefit was that this campaign was also used to drive referrals to our clinical pharmacy program, which allows our patients to, have a longer appointment time with the provider. So I think in terms of expanding the care team and giving our patients, better quality, the buy-in was happened fairly quickly.
Nice. And was that, since the care team was expanded a little bit, did that help the clinician buy in a little bit as well?
Exactly. So same as with the clinicians, because of the referrals to the clinical pharmacy program, it wasn't necessarily that we were, driving patients or increasing, scheduling conflicts with clinicians. So the buy-in from both leadership and clinicians happened fairly quickly.
Wonderful. Thank you so much. Stephanie Smith, same question for you. Leadership and clinician buy-in.
Sure thing. So in terms of leadership buy-in and clinician buy-in, we did have our internal clinicians, including our chief clinical officer and our Epic physician champions, take a look at the survey that was developed from that network perspective to understand the questions that were being asked. We did also engage our participating health centers to share that as well within their leadership teams so that they can also have their individualized conversations at that level of the importance of the survey, kind of the purpose of it, and how it's going to be used to enhance some of the quality opportunities that were on the table for them. So I think that was part of the buy-in process, was knowing that as a health center controlled network, we were able to develop something like this tool to help send it out, and so that they had additional data to assess. Sometimes provider meetings could get very busy with different agenda items and different important topics. And so helping them gather this data and just promote it individually, I think was very helpful from a buy-in perspective.
Absolutely. It really helps to start with the data, doesn't it? So just want to remind everyone, please go ahead and drop questions into the Q&A. We want to hear from you. We really want to hear what questions you have in order to lift up some of the similar interventions at your organization, whatever that organization may be. So I'm actually going to start with Stephanie Smith this time. And I feel like we all are busy. Some of us are even overwhelmed, you could say. So what are some creative ways did you find to spark engagement in an already busy health center staff?
So great question, Chris. I think one of the important tactics that we have to think about when we talk about quality improvement metrics and reviewing them is that sometimes it can seem very mundane, right? It does feel like there's an additional burden where you're asking your clinical care teams to take a look at other data points throughout the process of their role. But I think something that helps to engage some creativity is exactly the example of BCOM and how they were able to utilize a trophy kind of mechanism to help get people engaged and have that spirit of creativity to go ahead and say, we're going to recognize our staff that are going above and beyond in the metrics, rather than just having that kind of be a static spreadsheet with some data points on it. So I think thinking through how you can give a facelift and how you're recognizing your clinical care teams in quality improvement helps to spark that engagement and creativity.
That's wonderful. I love that. So really giving life to those data, they can get dry at point, and definitely that recognition definitely helps. Right, Dr. Courtney?
Yeah, so we again, because this required, limited engagement. So we did take the data regarding medication intensification and how rapidly that can have an effect to our all staff meetings. So to both our provider, we went to the provider meeting, and then the meeting that we have with all of our CRRs and our schedulers, and presented the data about how quickly medication intensification can have an effect on uncontrolled hypertension. We demonstrated that it takes 1 in 7 visits to add a class of medication. And so because this was like a limited engagement needed, and because of the benefits of kind of driving these referrals to our clinical pharmacy program, that was the kind of the engagement that our team needed to implement this intervention.
Yeah, that's wonderful. Sometimes you really need to have some of those conversations, and whether it's a trophy or whether it's having one-on-one opportunities for questions to really bring the data to life are helpful. Thank you so much. All right. So I'm going to start with you again, Stephanie Smith. Tell me a little bit about what you thought about the 90-day activity. Was it successful?
Sure thing. I thought it was very successful. I think that there were a lot of interesting data points that got uncovered in the process. As I had mentioned, just kind of helped to clarify some of those instances where maybe the guidelines didn't seem as clear to clinicians and care teams, and passing that data on to health centers. And also thinking about how we can incorporate some of those survey questions in our clinical decision support tools that are available to health centers to help give us some context in terms of how can we optimize them so that they're more efficient for the care teams at the point of care to help facilitate the conversation around statins. So I would feel that it was a very successful first time around, and we were looking forward to thinking about doing it again for next year and beyond.
Okay. Are you going to do it in the same way next year, or are you thinking about changing anything up?
I think we may change up some of the questions in relation to then engaging other clinical decision support tools we have. So, as an example, our Epic Physician Champions have created different smart phrases that can be included in the encounter with the patients that are having that conversation around statin therapy initiation, especially since there were some changes too recently in the 2024 measure for statin therapy and that addition of the fourth population that includes an assessment of the ASCVD risk. We'd like to see some more data around that, usability, and just understanding ways to optimize that in future surveys too.
Well, yeah, the goalposts have shifted slightly, and you're keeping up with that, which is wonderful. All right, Dr. Courtney, same question for you. What are your thoughts, feelings of the 90-day activity?
We're really excited to look at the data from this activity. We absolutely think it was successful. We sent 338 text messages. Of the 338 text messages we sent, 109 people had completed an appointment within 60 days. And then of those individuals, 55% had added a class of medication. And then of those 55%, about 92% now have controlled hypertension. So we are absolutely excited to do it again. And we actually already have. We've sent out the second round of these text message, like campaign style text messages that are targeted. And we're excited to look at the data when it comes back.
It's wonderful. That's really great outcomes. Appreciate that. You can see a lot of reactions happening in the chat there. So there was a follow-up question, I believe, for you, Stephanie Smith, of the survey platform used in the provider engagement and development survey.
Sure. So I think some of the most surprising questions that we saw in terms of responses in the survey were, especially when the guidelines were not clear, were thinking about how patients with multiple comorbidities, maybe they have an HIV diagnosis in addition to that hyperlipidemia or ASCVD. And so there were a lot of opportunities that we saw in reference to that component of where the guidelines maybe were not as clear. And so we took some of those data elements we have a monthly cardiovascular health work group as well that's led by Antoinette Anwar. And we do that in conjunction as well with our sister network, Alliance Chicago. And so we use that platform to actually get out education to all of our health centers around some factors to consider in terms of when the guidelines may not have been as clear for helping those patients with those comorbidities. And so that was just something we found very interesting within the data points that was a quick educational standpoint for us to promote at that work group and share resources for health centers to send the message as well to their clinicians.
Wonderful. And in those work groups, did you find any other interesting ideas that people had as well?
Yes, I think there were a lot of conversations around lifestyle, as you can imagine, with thinking about that LDL risk group. So one of the other branches from that discussion were inviting nutritionists from organizations, so from the health centers participating in our grant. As an example, a nutritionist from Jesse Trice Community Health Systems was able to join one of those sessions and actually talk about what strategies she has in place when she talks to patients around lifestyle modification, diet changes, so that there could be some further discussion around that and a game plan for patients to help make those decisions.
All right. So, can you tell either of you you talked both about training and other opportunities. Can you talk a little bit about how you train staff on these different tools for optimization? Stephanie Smith, you did mention the monthly work groups that you have, but any other insight, especially boots on the ground, would be helpful.
Sure thing. So to help with the training components, we do have our Epic Physician Champions within a clinical advisory council, so our clinical governance process. That's an opportunity where there is a demo provided by one of the physician champions, specifically Dr. Ross Collazo, who helps lead a lot of the different CVD related efforts at our organization. He'll do a demo within that space. So then it becomes kind of a recorded snapshot of those optimizations, how to use the smart phrase, how to pull that into your note, knowing where to find where the ASCVD risk calculation is being done, even adding those different data points within the schedule as well to help for pre-visit planning or huddles with clinical care teams. And so as a follow-up to those demos and discussions, we also develop different tip sheets, so educational materials that apply that train the trainer approach so that they can also get the word out with teams. And we're also happy whenever we need to schedule time individually with those clinicians. Sometimes there's different opportunities where the physician champions may join those meetings as well as provider meetings, as I discussed earlier with health centers, to do exactly a targeted session around what is out there to help for statin therapy and other CVD related education.
Thank you so much, Stephanie Smith. And Dr. Courtney, any other additions on training for staff?
Yeah, so we, in addition to, taking this campaign style intervention to our provider group, we did provide medication intensification training in general to all of our providers, and then also provided all of our providers with um, a formulary that we have that include single pill, combination therapy medications that are covered by our, by our organization. Some of the other things that we did, we made sure that when we talked to the call center staff, we took into account their concerns and included in our messaging that, in the text message to talk to the provider, because we didn't want the health center staff, or I'm sorry, the call center staff taking or having to take questions about hypertension medication or hypertension in general. And then we also very specifically included in the wording of our text message, like single pill combination therapy. So that way individuals wouldn't think that by just stating combination therapy, that we were saying that they needed to take more medications. So those are some of the things that we also took into account.
So I'm just curious, did patients react well to that single pill combination therapy? Did any of them ask questions or get confused or?
I haven't actually followed up with the providers to, or our clinical pharmacists to see what exactly within that might be something for the next round that we take into consideration as a survey of those patients that, responded to the text message. And if that single pill kind of wording is what was one of the driving factors. But of the individuals that added a classification of medication, 55 of the 60 went from whatever level they were on to combination therapy.
That's extremely impressive. I
Mhm.
think others would want to replicate that. I have another question for you too. Thinking back about the medication intensification, you mentioned earlier about the current guidelines and that people weren't aware, or some clinicians weren't aware of that. And really any other thoughts on how you gently re-educated clinicians that might have been taught differently? You talked about the formulary, but any other tools that
Sure.
were
Yeah,
helpful?
we actually had one of our the OCHIN informaticists and data individuals come in and provide a training during our all provider staff meeting, our monthly provider meeting. So they came in and actually provided certified training on medication intensification and the current guidelines. And it
Oh,
was
that's
great
wonderful.
because they were able to answer questions that I could not about the different pharmacy medications that fall into those classifications.
Definitely. It helps to have that expert there with that. And both of you had talked a little bit about the monthly meetings. There's so many different conditions. How are you able to really prioritize hypertension and cholesterol management within everything else that they have to cover during the meetings? Anything to make it easier or put it in?
Sure thing. So when it comes to the different disease focused areas within our organization, we do have an overarching clinical quality work group that we host on a monthly basis that covers a variety of different topics. But when it comes to disease related items or chronic disease related items, we have, as I mentioned, our cardiovascular health work group that focuses on both hypertension, and cholesterol management related items. So there's a targeted group of health center champions that attend those sessions. We also have similar forums for HIV as well. So we have an HIV task force. And we just recently actually launched a pharmacy work group. So hearing a lot of the work that you shared, Dr. Courtney, it's definitely inspiring me to think about how we can incorporate more of the conversations with clinical pharmacy too.
Yeah, similar to what Stephanie mentioned, we also have a monthly quality improvement planning committee and steering committee that meet monthly. And we rotate through different projects, but hypertension and diabetes was identified before COVID actually, but then especially after COVID, we realized and identified that many people might have foregone care, just seeing a provider on a regular basis. And we identified that as like one of our priority areas for quality improvement.
Absolutely. Something that a lot of people are struggling with. It's definitely a high priority. Glad to hear that it is that in both of your organizations. All right, so let's talk about other types of concentrated activities that should be considered to make major progress, in efforts to improve blood pressure control or cholesterol management. Just any of your top 3 ideas. I know you have the top 3, but really things that are low-hanging fruit that you can really see progress quickly, because I think that really helps your care teams, keep their momentum going.
Yeah, I can speak to that. For us, I think and for me and my work is that I think the most important thing is using data to inform our decisions, because again, everybody is, strapped for resources and time and, engagement. So using the data that we have available to just target our interventions, I think is the best thing to do. Low hanging fruit being people that are uncontrolled and that are active patients in their own care, but are on no therapy and have uncontrolled hypertension. So I think that was just identifying that and using that as a basis for a starting point, was like the best thing that we did.
Absolutely. And you mentioned earlier about using the data to target monotherapy and no therapy, which is great. Sometimes there's been some confusion and people are like, will start with a no therapy and they're just trying to get people on monotherapy. How did you avoid that and make sure that they did get the single pill combination?
I think just again from having it's kind of the training going both ways. So our clinical pharmacy team is aware of the implications of going directly to combination pill therapy versus monotherapy. And then having the training for our providers just to remind them and to show them that, what are the benefits, and then what, that it takes 7 visits with a provider on average nationally to provide that intensification. I think showing that both ways provided the best result, I guess.
Well, thank you. All right. So Stephanie Smith, I think you've been with us for quite a while now, and so if you have anything for both cholesterol and blood pressure, please let us know. But what other kinds of concentrated activities?
Sure thing. So I want to also build up from what Dr. Courtney was sharing about leading with data. And sometimes I think about concentrated activities. Sometimes I think about going back to basics, right? And using the data on the basics to understand where it's best to branch out. As we were saying earlier, right? There's so many things to consider within that patient visit, so many kind of targets to think through, care gaps that have to be addressed. And so times knowing the education around the basics that look at guidelines, right? Like why are the guidelines kind of designed the way they are, and promoting education around that can be extremely helpful. There's been a lot of discussion also within our groups for the statin allergy component. And so I think in the future, when we think about that, like developing a little bit more education around what that looks like in terms of conversations with patients that are experiencing some sort of statin allergy or maybe some muscle side effects or something to that degree, and what does that conversation look like? in terms of reconsideration. Maybe that's not ideal for the patient. Is that another thing to think about, especially if they're in the ASCVD risk group? So I think in terms of concentrated activities, thinking about what are those kind of basic elements that you can build upon and kind of dedicate some time to, whether it's in provider meetings, even care team discussions as well. If you have other clinical support staff at the health center that are responsible for assisting providers with closing some of these gaps in reference to cholesterol or hypertension, having them also be a part of that education and understanding around the guidelines and the importance.
Absolutely. So we love the trophy. We love Broward County's trophy. Have either of you thought of other ways to really share your results with staff, or celebrate, or even hearing each other talk today? What are some ways you want to integrate that in a meaningful way?
So I think from our perspective, one of the things that we want to get back to sharing overall is just quality improvement data across a network. And so we've developed a lot of great resources with like a UDS executive report as an example. And so building off of that and just doing a branch out that's focused on quality improvement efforts, and maybe even seeing, from that perspective, promoting the competition amongst health centers. We always try to make that a conversation in our clinical quality work group on, who's kind of doing the best in a certain measure, what are some tactics that they can share around that, and making sure that it's easier to share some of those wins and get people excited about who might be, in a first, second, third capacity. So that's one way I'm thinking through engaging.
And just to follow up on that, Stephanie Smith, when you talk about like the different things that people are doing, are those sometimes MAs or nurses or other expanded care team roles that are able to be lifted up and show others what great work they're doing?
For sure. I think that those care team members are vital in the process because they may be kind of that first discussion with patients, maybe in preparation for the formal visit with providers, or even in between. So if there's care coordination staff, one of the workflows that we've worked on with our participating health centers is sending out some of those statin education tools that have been developed through the Million Hearts Project to patients, maybe in advance of that visit. And so giving the patient an opportunity to assess that educational material, have an opportunity to ask questions, or just be exposed to some of the things that the provider will discuss with the patient in regards to that.
Wonderful. Thank you. It sounds like clear and consistent communication, from start to finish. That's wonderful. Dr. Courtney, anything else? How you're celebrating, with the clinicians and nurses and pharmacists and all the care team?
Yeah, so we actually just put this just actually took a look at the data in preparation for a conference, the Ocean Learning Forum that just took place last week. So this was our first like deep dive into the data as a result of these text messages. We've already, submitted the second round of them, but to go back, 90 days and look at what occurred over those 90 days. So we're actually providing this data to our quality improvement steering committee. I present next month, so in a couple of weeks, and then taking it back to our provider meeting at the beginning of the month. And then I've already shared the data with our casework associate who is in charge of our bidirectional software. And so we're really excited that this is something that you can see very clearly has had an effect. And we are excited to maybe try and use this in other areas as well. So we're just starting to share this, but hopefully we get to share it with everybody.
And to the two Stephanies, Judy Hannon from the Million Hearts Initiative, I just realized I was thanking you earlier before we got started about doing this presentation, but I neglected to say, please make sure you thank all the staff as you're sharing the data. We truly believe that so many heart attacks and strokes and other cardiovascular events can be prevented, but the hard work happens with the care teams that you're talking with. So as you're sharing the data, if you don't mind sharing thanks on behalf of CDC and the Million Hearts Initiative for the hard work, I would appreciate that because they have my thanks.
Thank you so much, Judy. And we appreciate your leadership. I think everyone feels very seen with you at the helm of this, you and Larry at the helm of this. So thank you. And amazing work. Stephanie Smith, Stephanie Courtney, really appreciate all these wonderful results. And you really showed us that, yes, we can in 90 days make significant impact. So thank you so much. And I will turn it over to Lauren.
Thank you so much, Chris and Stephanie for that great discussion. Before we'd end, I'd like to highlight a few resources. NAC is really proud to share the quality improvement roadmaps that Chris mentioned earlier for our Preventing Heart Attacks and Strokes project online. And so for all the resources that I'm about to share, you can either scan the QR code that is on the slide to pull up the resource, or you can grab it from the link in the chat, and we will be sure to include all of these resources in our follow-up email as well. We also want to mention that the CDC has recently updated their cholesterol management change package, and they also have a similar package of resources for the hypertension control that has been posted online. So again, feel free to grab that from either the chat or the QR code. NAC also just published a patient education resource that clearly outlines the effects of uncontrolled hypertension in easy to read language. And so we invite anyone to use this resource. And again, feel free to scan the QR code or grab it from the chat. And lastly, I want to mention that the CDC just dropped a new resource last week, the Hypertension in Pregnancy Change Package. Again, feel free to scan the QR code or grab it from the chat. And this is a great segue into our next learning lab, which will take place on July 11th and will feature topics that are highlighted in the Hypertension in Pregnancy Change Package. We will send an email with more information on how to register for that learning lab, as well as who the speakers are once we've confirmed them. But right now you can scan that QR code to pull up the Zoom link to register if you haven't already. Finally, CEUs will be sent out in a link shortly, so please keep an eye on your inbox for both the link to the CEU as well as the session password to claim those credits for today's session. And we would like to thank you all so much for spending your time with us today. And once again, like to thank our speakers, Dr. Stephanie Courtney, Stephanie Smith, and our moderator, Chris Esperson, for sharing their expertise today. We hope you all have a great rest of your day.